The meeting will come to order. I'd like to welcome everybody this morning. My name is Dan Elliott. I am chair of the California Technology Assessment Forum, otherwise known as CTAF. I'd like to say a few words just to explain CTAF, which is a core program of ICER, and as such, reviews ICER-produced evidence-based reports on the safety, effectiveness, and net health benefit and value of healthcare services. In doing so, CTAF provides a public venue for discussion among all stakeholders. CTAF's mission is to help patients, clinicians, insurers, policymakers, and others interpret and use evidence to improve the quality and value of healthcare. CTAF's vision is a future in which collaborative efforts to move evidence into action becomes the foundation for a more effective, efficient, and just healthcare system. I'd like to comment on the conflict of interest policy. Our conflict of interest policy is provided in your packet. And individuals making public comments at this meeting should disclose their relationships, if any, with industry or any other potential conflicts of interest related to today's topic. All members of the CTAF panel have been asked to disclose their conflicts of interest related to today's topics, and the only one is myself. I recuse myself from any vote on today's topic because a person related to me is a principal, a partner, in a venture capital firm which has provided financial support to one of the companies providing diabetes prevention program services and is included in today's discussion. Having declared this potential conflict and after discussions with senior ICER leadership, I will not vote, but I will chair the meeting and will participate in today's discussions. At this point, I would like to introduce
me,
Jed Wesberg. Jed is a senior at ICER. He has a long and distinguished career at Kaiser Permanente. He's a gastroenterologist by training, and he will introduce the topic today and lead our discussion. Jed?
Thank you, Dan. We are going to have a very interesting discussion today, both our summary of the evidence and the roundtable discussion this afternoon. To start, Siri, do I have prediabetes?
No comment.
Siri should have read the report knowing that I was going to be here today. But perhaps artificial intelligence is akin to artificial sweeteners. It lacks a certain something. So why are we here today? Well, I'd ask Matt to show an image from the internet. This is a headline from the Washington Post. Burger King's latest fast food monstrosity is sadly genius. And it shows how they've taken mac and cheese, coated it with Cheeto dust, and fried it. Right, I'm glad you don't have a full stomach, Joy. That's very good. Okay, let's go to our next slide. So why are we here today? It's because we do exist in what's been described as a toxic food environment, a topic for our roundtable as well this afternoon. And because of the sheer magnitude of the issue in the United States. If you add up the numbers in our report for the number of people with prediabetes and diabetes, we're talking about a third of the country. So if we look to our right and look to our left, and those people look in pretty good shape, think twice, get tested. We're also at the nexus of a public campaign that the AMA and the CDC are sponsoring, and we'll hear more about, that's urging active outreach and screening for blood sugar levels for identification of both unrecognized diabetes and prediabetes. And at the same time, we're at a period of policymaking from CMS where it seems they'll be expanding coverage for some of these diabetes prevention programs. So the time is ripe for both private and public payers to try to figure out how they're going to deal with the evidence of efficacy, which comes from a now decades-old trial whose results were published more than 10 years ago, but whose scale-up and transformation into real-life pragmatic programs is reaching its flowering point. So there will be a lot to speak about. So what are the Institute for Clinical and Economic Review and the California Technology Assessment Forum? There is full description in your notes on your desk and on the website, but suffice it to say that ICER exists to try to have an objective process for talking about the health benefit, the care value benefit, and the overall system impact of new medical interventions. We look at drugs, we look at devices, we look at medical interventions and health system changes. So, for example, we looked previously at bariatric surgery, new devices to help lose weight. We've looked at the integration of behavioral health into primary care. And today we're looking at diabetes prevention programs and how they mesh with the variety of public health, individual health, employee health, and medically covered health benefits that are out there. You'll see that we do some interesting calculations. After we derive our net health benefits, we turn to our economic reviewers who survey the field and give us a sense, a flavor, for what cost effectiveness at the individual level might indicate, as well as what the overall budget impact and perhaps value for the health system might suggest. So this report came about because the advisory panel for CTAF, the California Technology Assessment Forum, which is founded many years ago by the Blue Shield Foundation and is funded by the Blue Shield Foundation, the Laura and John Arnold Foundation, and the California Healthcare Foundation, suggested that we look at additional health system interventions, since that is what people who are running ACOs, integrated health networks, risk-bearing entities need to think about as they're contemplating how to build health in a population and not individually treat episodic episodes of illness. So the topic was suggested. We go through our usual review. You'll meet our evidence reviewer, Dr. Jeff Tice from UCSF, who will be presenting all the evidence. We'll meet Dr. Karen Shore, who looked at the policy landscape in California and more broadly across the nation. And you'll meet Dr. Rick Chapman, who provides the economic analysis and overview. And we'll have a chance to hear the evidence. Then our panel, you'll see, will be asking any questions of the people presenting the evidence prior to lunch, when we'll be going, lunch will be available here, and then we'll be coming right back from lunch to do our voting. And the voting will be on the questions there in your packets there as well, about the net health benefit of the various forms, modalities of these programs as we've organized them for discussion and analysis, as well as the care value, blending in the economic focus. Following the votes, we will invite a number of experts, including a patient, the most expert person themselves with this condition, up to the round table, and we'll be having a broad-ranging discussion of how the results of the evidence presented should impact the healthcare system and what are the broader issues that perhaps go beyond the evidence at hand today. So, Matt, in graphical format, we will be looking at the comparative clinical effectiveness and a public discussion at vote. Then we'll be inviting our panel to take that base, blend in the incremental cost for better outcomes, any other benefits and disadvantages, contextual considerations like 1/3 of America has prediabetes or diabetes, to get to the care value vote. Okay. So I've already reviewed briefly the agenda for the day. Next slide. One interesting aspect for today's meeting that is not necessarily part of every CTAF meeting is that a number of the innovators in the private marketplace who have tried to find ways to scale up the intervention that will be described from the original diabetes prevention trial were invited to be here today. And a number of them took us up on the invitation, and they will be invited to make 5-minute comments about their view of the state of the literature, the evidence as presented, and looking forward. Other than that, the meeting will go very similarly to other CTAF meetings, and you will hear the wisdom from our panel expressed as we are moderated for the morning by Dr. Dan Uliet. Next. Go ahead. Huh? Yes, for those who are viewing this via webcast, there seems to be some technical issue with the advancement of the slides. So be aware that you can go and download the slides and look at them yourself from the CTAF.org website. And then I guess I should point out that the restrooms are not in the Emerald Ballroom. The Emerald City does not have all of the facilities one might need. And you have to exit the hall, make a left, then go down 3/4 of the way down the hall and make a right past all the pictures of prior Oscar events here. And by my calculation, it's 340 steps to the men's room. So you can start getting your exercise in for the day. Matt, anything else? Okay, let's go on. So with that, I'd like to introduce Karen Shore, who's a principal in a Sacramento healthcare consulting company called Transform Health, but is a dear friend of CTAF who used to be the program manager here. Karen.
Thank you, Jed, and good morning, everybody. So as Jed mentioned, and I'm delighted to be here to talk about the policy landscape. So in addition to the typical CTAF review of the clinical effectiveness and economic aspects of a topic, this time for diabetes prevention programs, or DPPs, we also conducted 34 phone interviews with various folks, key stakeholders who are involved in designing and delivering these diabetes prevention programs, including perspectives from federal and state government, from public and private payers, as well as purchasers, from patient advocacy organizations, and was mentioned the various vendors that are here today. So findings from those interviews and our other research supplement the clinical and economic analyses and fall into the landscape sections of the report and into my remarks today. So look forward to sharing this information with you all. And so I have no conflicts of interest. Just a little bit of a background to start with. So it's estimated that 86 million American adults have prediabetes. And what this means is that their blood glucose levels are higher than normal, but not high enough to be diagnosed with diabetes. So of those folks, about 90% don't know that they have it. A recent study in California done by UCLA, in our backyard here, estimated that 13 million adults in California have either prediabetes or undiagnosed diabetes. Most of those are believed to be in the prediabetes category. I think only about 4% have undiagnosed diabetes. But as you can see, the prevalence is higher among certain racial and ethnic groups than in others. And prediabetes is typically identified as having a fasting plasma glucose, or FPG, between 100 and 125. And Dr. Tice is going to talk about this more later, but there's some debate about whether the appropriate threshold for prediabetes diagnosis is 100 or 110. And if 110 is used rather than 100, the number of people estimated to have prediabetes would drop by about 55 million to 31 million, but still 31 million is quite a significant number. So there are interventions that are designed to prevent or delay the development of diabetes, and these can both improve individual health and quality of life through disease avoidance, as well as save medical costs by reducing the incidence of diabetes and associated complications with that. And without those kinds of interventions, it's estimated that 15 to 30% of people with prediabetes will develop type 2 diabetes within 5 years. And so there's a seminal study called the Diabetes Prevention Program Trial, or the DPP trial. And Dr. Tice will talk more about this in his presentation, but it was a randomized control trial that had over 3,000 patients followed for many years. And this is the study that showed that the incidence of diabetes can be reduced through intensive diet and lifestyle counseling, and that it was an approach that was more effective than using the drug metformin. So a couple of key results to share from that study. There was a 7% average weight loss after the first year, and also a 58% decrease in the risk of progressing to diabetes in 3 years. And we'll hear a lot about weight loss today. It's used as a surrogate measure by clinicians, often for effective prevention of diabetes. So after this DPP trial showed the effectiveness of a lifestyle intervention, there were many types of programs that evolved to address this need. And CDC wanted to find a way to recognize those that were willing to commit to certain activities. So they established a Diabetes Prevention Recognition Program, or the DPRP, for organizations that were willing to meet these standards. So having an approved curriculum that promotes 5 to 7% weight loss and increased physical activity, uses a lifestyle coach, and this can be either someone who is a healthcare professional or a trained layperson. Both can be effective, and I think that Dr. Albright will say a little bit more about that on the policy roundtable this afternoon. And then also has a peer support group of program participants. And to achieve recognitions, the programs must submit data annually the data that are gathered are on weight loss, physical activity, so there are actually logs of these things, and then how many classes that people attend. So CDC uses these to assess the program impact. And both digital and in-person programs can be eligible for recognition through CDC, and the online programs only were able to start that process last year in 2015. And there's two types of recognition, full and pending, and this is an ever-increasing number, but at the end of March, there were about 840 programs that had either full or pending recognition, about 54 with full recognition, and the rest with pending. So interestingly, these programs are taking place in lots of places, not just medical settings, so in churches, community centers, work sites, and other places across the country. Organizations can develop their own content for a DPP and submit it to CDC for their review, and if it's approved, that can make them eligible to be recognized through the DPRP. So what do these programs look like? So this table summarizes the key features of these types of programs. So the DPP trial, that involved one-on-one in-person counseling with a medical professional. So as you can imagine, that was very expensive, costing about $1,400 per person in the mid to late 1990s when that study was done. But after that program was shown to be effective, there was a desire to get these programs out to a lot more people and at a lower cost. So programs then began to be developed that were in person, but in a group setting, so rather than one-on-one. And the Y, which is formerly the YMCA, was one of the pioneers in implementing and studying these programs. They typically meet in a group environment of 8 to 15 people in person once a week to go through curriculum lessons. And they're typically led by a trained layperson rather than a healthcare professional. There are some other in-person group coaching programs that do have healthcare professionals as coaches. But so there's definitely some variability among that second category there. So in terms of cost, we think that these types of programs cost about a little bit less than half of the original DPP. And to further expand the reach of these programs, their digital solutions began to be developed. So these are programs that can be accessed online, so you can go on your computer, your tablet, or your phone and get your curriculum lessons delivered electronically. And these programs fall generally into two categories, those that involve human coaching and those that do not. They're fully automated. So those that use a human, either, again, it can be a trained layperson or a healthcare professional, deliver tailored messages to participants in a group by email or text. So, and there may be a virtual group where 8 or 10 or 15 people who are in a group together can interact with each other using a message board, for example. And by contrast, the last category, the digital fully automated coaching, involves no human coaches, but rather messages that are delivered to participants automatically based on behavior that they enter into the program. So if their goal was to take 5,000 steps a day and they made it to 2,000 instead, they might get a message saying, here's some additional ways that you could add steps to your day. I'm vastly oversimplifying what goes on there, but just to give an idea. So this is known as the algorithmic or fully automated approach. And in terms of cost for the digital programs, those with digital and human coaching are pretty similar to the in-person group coaching, again, about half of the original DPP, whereas the digital fully automated or algorithmic are the lowest cost in the range of $50 to $75 a year. So as you can see going down the table, scalability or the reach of the programs increases with the movement toward initially group coaching, and then towards the digital programs, and the cost decreases. And you can see what the key resources are for each as well. Kind of starting out with you need people and places to hold meetings if you're doing this in person, whereas if it's moving down to the completely algorithmic, it's a technology as the kind of the rate limiting factor there. And there's pros and cons to each of these settings, and different types of settings will be more attractive to different types of people. So, the individuals who are thinking about a DPP should think about what's important to them. How do they want to get their peer support, for example? Do they want to go every week to the same location, so a predictable thing to do, or do they want to go online whenever it's convenient for them to do that? So again, people need to think about what's, kind of what works best for them. So as I said, very cursory overview, and look forward to hearing from the vendors who are here today about their more detail about their programs. So turning a little bit to the national landscape and what's going on throughout the country. So the Centers for Disease Control and Prevention, or CDC, leads the National Diabetes Prevention Program, or NDPP. And this is a public-private partnership where they're working to offer evidence-based, cost-effective interventions, looking both to reduce prediabetes and type 2 diabetes and to scale them up. There's a new curriculum that was released by CDC in March. It's called Prevent T2, and it reflects new literature on self-efficacy, physical activity, diet, and sleep. This is a curriculum that's free to anyone who wants to use it, available on the CDC website. It's developed both in English at the 6th grade reading level and in Spanish at the 5th grade reading level, not a translation for the Spanish, but actually developed in Spanish. So it's a one-year program, something that a lot of people don't recognize. They think, it's 16 lessons or something like that, but it's actually a year-long program divided into 2 6-month segments. The first has 16 modules that are all required in the first 6 months, and then 6 of the 10 remaining modules have to be delivered in the next 6 months. So there's an appendix table. It's in the key tables. It shows you the list of all the topics to be covered in the curriculum per CDC, but some examples include something that we probably all think about, healthy eating out. So if you're going out to eat, what can you eat that's a little bit more healthy, how to manage stress, how to stay motivated, how to keep from sliding backward. And then turning to California, what's going on here? So California Department of Public Health, or CDPH, is the leading state organization working on diabetes prevention, and they have received a couple of grants from CDC, again, both to increase awareness of prediabetes and the number and use of the programs in the state. And CDPH shares these funds with the local health departments, who are kind of on the ground and know most well what would be helpful to the folks in their counties. And there are also 2 cities in California, Los Angeles and San Diego, that receive CDC grants to work in this area. The state's also partnering on, as Jed mentioned, the Prevent Diabetes Stop program. This is with CDC and AMA. The program targets information to everybody involved, so patients, providers, and employers and insurers, and really trying to get patients to be screened for prediabetes and participate in a program if they have it, get providers to screen people for prediabetes and refer them to these programs, and then both to get employers and insurers to cover through health insurance these programs. So there's also a statewide action plan being developed here in California to address prediabetes. The stars did not align, as that meeting is happening in Sacramento today. They're talking about how they're going to do that. That's led by CDPH, and lots of multiple different stakeholders involved in that meeting. So we look forward to coordinating with them after today and hearing what they were able to talk about and move forward. Their action plan, I believe, will be implemented in the fall this year. So we wanted to look at the match between the need for diabetes prevention and the programs that were available. So this map, sort of our best shot at that. We didn't have information on the prevalence of prediabetes by county, but we were able to get it on diabetes. So we use that as a surrogate. So on the left graph, you can see that diabetes is more prevalent in the Central Valley and in other rural areas of the state. And on the right graph, you can see where the programs are. And there's a mismatch between those two. So we'll leave it with that. There's some footnotes I could go into on the table, but I'll skip that in the interest of time. So we talked a lot with the folks that we interviewed about implementing diabetes programs and what needed to be a sort of front of mind for folks as these programs are being implemented. So the first thing that people talked about almost to a person was increasing the awareness of prediabetes. So there's several state and national efforts underway to increase awareness of prediabetes, both among individuals who could have that, as well as among healthcare providers. People talked a lot about a need for greater provider awareness and referral to DPPs, and then a need for better linkages between healthcare providers and diabetes prevention programs, particularly the community-based ones. Another significant issue is scalability, so how to reach a broad audience. If really 1 in 3 people have prediabetes, how do we reach all those folks at a lower cost? For the programs that use human coaches, there were, people talked a lot about extensive efforts being needed to identify, train, and retain skilled coaches, these lifestyle coaches who could connect to the communities being targeted by the programs. To a person, I think what we heard was one size doesn't fit all. So not every program is going to be right for every person, and we really need information on what type of DPP works best for whom. Sustainability is another key issue. So there's a history of grant funding for some of the in-person programs in particular. This is not a good long-term model. And many of the community-based programs did not have a provider number, so they couldn't bill insurance, and they're not typical kind of historic business partners in any event. But the marketplace is evolving significantly. Some DPPs are being paid based on the number of people who enroll and achieve certain milestones of attendance and weight loss goals, rather than just a fee per person offered the DPP. So that's a significant change to a pay-for-performance approach. And there are also emerging intermediaries who are partnering both with the plans and employers on the one hand and with the DPPs on the other to increase the offerings for purchasers and also to drive enrollment and funds to the programs. And last, so many people talked about the need for curriculum being available in a language that participants can understand and that is culturally appropriate, especially noted here in California, a need for materials in a variety of Asian languages. There's also, people talked a lot about a need for strategies to reach underserved communities with populations who are particularly high risk of diabetes based on either race, ethnicity, literacy, or income. So we heard one example. So I told you earlier that organizations can submit their own curriculum to CDC for review and potential approval to be recognized in that program. So we heard an example. These people hadn't done that, but they had developed a pictorial version of a DPP, particularly for use among those with low literacy, and thought that this might be a potential way to go for that. And then for lower income populations, we heard that participation and attrition were both significant concerns. So lots to think about in terms of the implementation. So there is lots of activity currently going on in terms of coverage around diabetes prevention programs, both nationally and in California. People may be familiar with Medicare's announcement, I believe it was in March, to expand coverage to all beneficiaries at a high risk of developing diabetes. They are actually using the 110 threshold. So I said before it was either 100 to 125 or 110 to 125. The proposal, I believe, is to limit it to the 110 to 125 group, and the rulemaking process is underway. Medicaid, there's only one program, which is Montana, that covers DPPs currently, but 2 states, we were told just recently, Maryland and Oregon, will be starting pilot projects to test DPP coverage, and hopefully, again, Dr. Albright will talk a little bit more about that this afternoon. In terms of private plans, some plans are covering them for some populations, and the interest seems to be increasing. That may be somewhat based on 2 relevant task force, U.S. Preventive Services Task Force recommendations related to coverage of lifestyle programs for certain patients. And In addition to that, last week, the American Medical Association adopted a policy at its annual meeting, really encouraging private and public plans to include the DPP as a covered benefit for their beneficiaries. And then in terms of employer coverage, this is also variable, but we heard of some significant interest there, and CDC has been working, provided a grant to expand coverage for both public and private payers. And finally, after we posted our draft report, we heard from various folks who offered public comment. Two general categories. The first was language suggestions. So we were asked to talk more about the heterogeneity of the diabetes prevention programs, particularly those that are in person. Also asked to describe the effect of the DPP interventions as delaying or preventing rather than preventing the diagnosis of diabetes, and then to talk more about scalability considerations of these various programs. It was also suggested that we include a person with diabetes or pre-diabetes as a participant in the public meeting. So thank you for the folks who submitted those comments. We did address the language issues that were raised, and we are delighted, as Jed mentioned, to have an individual on the policy roundtable this afternoon who has participated in a DPP. That's it. Okay, Dr. Tice.
Thanks, Karen. You make my job easy, setting things up for me. So I'm Jeff Tice. I'm going to present the evidence review. I have no conflicts. As already alluded to, there are more than 86 million people in the United States with prediabetes. When the DPP trial was initiated, that number was only around 50 million. It was started in 1996, so we've seen an explosion of both diabetes and prediabetes since the time that this trial was designed and initiated. The trial, as Karen noted, randomized a little over 3,000 patients to either a lifestyle intervention, a medication, metformin, or a placebo group, and follow-up through 15 years has been reported, though there is ongoing follow-up for additional outcomes. The average weight loss at 1 year was 7.2%, and that translated into a 58% reduction in the incidence of diabetes at about 3 years. However, that decreased to only a 27% reduction at 15 years, and was, as was alluded to in the public comments that Karen talked about, really you could think about this as a delay in diabetes. If you look at the incidence curves from all three of the major long-term diabetes prevention trials, the one in China and the one in Denmark, in addition to the US trial here, you see that there's really a delay in diagnosis of about 2 to 3 years with these trials. And in the lifestyle intervention of the DPP trial, by 15 years, more than half of patients, 55%, had gone on to develop diabetes, even with the lifestyle intervention. The DPP trial itself had 16 core lessons. As Karen noted, they were weekly lessons presented one-on-one in person with a lifestyle coach. They were focused on diet, exercise, and goal setting, and then 8 additional sessions every month, again, one-on-one with that lifestyle coach, focusing more on problem solving, adherence, and reinforcement of the initial messages from the 16 core lessons. And there were 3 goals discussed with a patient at the outset: the goal of losing at least 7% of their initial body weight, of increasing their exercise to at least 150 minutes per week of moderate intensity exercise, which is just brisk walking. So this isn't intense exercise, as something that's achievable by most patients. And a final goal to reduce dietary fat to less than 25% of total calories as the mechanism to reduce total caloric intake and help to lose weight. Based on this trial and much other evidence, the U.S. Preventive Services Task Force gave a grade B recommendation, so it's recommended but not the highest evidence level, that individuals who screen positive for prediabetes should be referred to a behavioral health counseling program to improve diet and physical activity, and they specifically focus on the results of the DPP trial in making this recommendation. There's a second recommendation that's very similar for patients with at least one cardiovascular risk factor who are overweight, which has the same recommendation. And similarly, the joint American Heart Association, American Cardiology Organization recommends that obese and overweight individuals with hyperglycemia, that they should be referred to a high-intensity comprehensive lifestyle program like the DPP, again, one that includes at least 14 sessions and lasts at least 6 months. So there have been a large number of trials of programs implementing the diabetes prevention program approach, and a number of systematic reviews. There's one that I'm focusing on here, which was commissioned by the CDC, and looked specifically at 53 studies with 66 different diet and lifestyle interventions. Overall, the mean weight loss was much less than in the diabetes prevention trial, so about 2.2%, but there was a marked reduction in the incidence of diabetes overall, about 41%. And the other major finding from this review was that the more intensive trials, those that had more sessions, more intensive interactions with patients, had greater weight loss and greater reductions in diabetes. So for our review, we augmented that systematic review of lifestyle interventions, but limited the studies that we were considering to those with recognition through the DPRP, either pending or full recognition as described by Dr. Shore. And we included both randomized trials and observational studies, in part because we felt that the evidence was strong enough that the DPP-style interventions clearly decrease the risk of diabetes and weight loss and diabetes. So we found 10 studies in the literature, 5 that were randomized trials and 5 observational trials. 7 used an in-person group coaching approach. Most of them came from the Y and Weight Watchers, as well as the implementation in Montana. There were 2 studies of a digital approach where there was a human coach making asynchronous recommendations to individual patients, the OMADA and Canary Health programs, and finally the digital fully automated program, the Turnaround Health Alive PD program, described by Dr. Shore as well. This is a brief summary of the study quality. The Y programs, there were 2 randomized trials and 2 pre-post studies that were of poorer quality. Of the randomized trials, one was of good quality, one of fair quality, and randomized a total of 303 patients in the lifestyle arm. The observational data, many more patients. Weight Watchers, there's one fair quality randomized trial with 112 patients in the lifestyle arm, and so on. Among the digital programs, OMADA Health has one pre-post study, an observational study of fair quality. The Canary Health program has one poorer quality pre-post trial of only 50 patients, and of note, only 8 of those patients had prediabetes, so less evidence on the direct question of the efficacy of their program on reducing weight and the incidence of diabetes in pre-diabetics. And finally, there's one good quality randomized trial of the fully automated program, and 163 patients were in the lifestyle arm in that trial. Before going to the results of the individual trials, these are results from the DPP trial linking the weight loss at 6 months on the x-axis to the reduction in diabetes incidence at 3 years, the primary outcome from the trial. And those patients in the lifestyle arm who lost only 0 to 3% of their initial body weight had about a 35% reduction in the incidence of diabetes at 3 years. And there was a stepwise increase in the reduction in diabetes incidence with increasing weight loss, up to about an 85% reduction in the incidence of diabetes among those patients who lost at least 10% of their body weight, 10% or greater of their body weight at 6 months. So I put that by way of context for the results from the implementation trials. Essentially, none of the trials were designed to look at a change in the incidence of diabetes. They primarily focused on weight loss, in part because of the information I just showed you, and in part due to other analyses from the diabetes prevention trial that demonstrated that the primary predictor of decrease in incident diabetes was change in weight. It was not associated with change in diet composition, so the change in percent of total calories due to fat. It wasn't due to change in exercise. It really was mediated by weight loss. And that is why many of these studies were designed to look at weight loss rather than diabetes incidence. So on the far left in this figure, you see the DPP trial and the weight loss at 6 and 12 months. You see it's about 7%. The next set of trials are the in-person group trials, those performed at the YMCA, Weight Watchers, and the Montana demonstration projects, among others. You see there's some variability. One of the trials, the RAPID trial, had much lower weight loss, but the other ones were generally in the 5 to 6% range. For the digital programs with a human counselor involved, the average weight loss at both 6 and 12 months was between 4 and 5%. And then with the digital fully automated program, it was only about 3.5%. And that trial only reported 6-month outcomes. At 6 months, they then opened up the program to the control group. And the published data are only through 6 months. In terms of changes in glycemic control, the most commonly reported outcome was a change in hemoglobin A1C. In the original DPP trial, there were very, very modest changes in hemoglobin A1C, a reduction of 0.1% at both 6 and 12 months. In the YMCA randomized trials, there was a similar 0.1% reduction. So moving from an individual to group delivery of the DPP trial, you saw similar results, so evidence that it could be translated to a group setting. Within Weight Watchers, the one trial found a greater reduction in hemoglobin A1C. They only presented these data at 1 year, but it was 0.3%. The Omada Health intervention, their 12-month results showed an even greater reduction, 0.4%. And the Turnaround Health, the fully automated program, only reported 6-month outcomes. But again, despite the relatively modest weight loss at 6 months, remember this group only had an average of about a 3.5% reduction in body weight. They had a greater reduction in hemoglobin A1C, 0.3%. So those were the benefits. The harms, really, there were no significant harms. There were no excess of adverse events or serious adverse events in the randomized trials when you compared the lifestyle group to either placebo or a usual care comparison group. And in particular, people focused on outcomes potentially related to the increase in exercise, so myalgias, arthralgias, fractures, musculoskeletal injuries, and there were no significant increases in any of the trials. There are a number of controversies in these data. These studies are short. Most of them have only 1 year follow-up. Several did have 2-year follow-up, and that is noted in the report where applicable. But as you see with the results from the DPP trial, this is a long-term disease, and we need to see reductions that are carried out through 5, 10, 15 years and further. And there's a fair amount of uncertainty about how these programs will translate into long-term health benefits for patients. There's also controversy around the definition of prediabetes, as has already been alluded to. The major clinical trials, the Chinese, Danish, and the DPP trial, all used an oral glucose tolerance test where people took a standard dose of sugar and had their blood sugar measured 2 hours later and used that for the definition of prediabetes. That's somewhat onerous, and clinicians don't routinely do that in clinical practice. We mostly use either hemoglobin A1C or fasting glucose to define prediabetes. And it was alluded to, the definition using fasting glucose is controversial. The WHO uses 110 to 124 as prediabetes, whereas the ADA includes the 100 to 109 group. And the incidence of diabetes in that group is much lower. So the incidence of diabetes in patients with fasting glucose of 100 to 109 and no other abnormalities is on the order of 2% per year versus up to 10 to 13% in patients with prediabetes defined by an oral glucose tolerance test. And finally, in the literature, there is concern about labeling patients with prediabetes. A large number of these patients won't go on to develop diabetes at all, and now they're being told they have a health condition. As we know from data from the hypertension literature, this can lead to increased absenteeism from work, a sick persona. So there are harms by giving patients a label of having a disease. And when we're talking about a third of the U.S. population, this is potentially a concern and needs to be balanced with the benefits of actually intervening in these patients and preventing the onset of diabetes. Other potential benefits or disadvantages really revolve around the benefits of decreasing obesity in the U.S. population. The main driver of the increased incidence of both prediabetes and diabetes from the 1980s to now has been the increase in body weight, average body weight in the U.S. population. Reductions in weight not only should reduce diabetes and cardiovascular disease risk factors like hypertension and hyperlipidemia. They have the potential to reduce arthritis, sleep apnea, esophageal reflux disease, and also improve quality of life. There are data that exercise and better BMI result in improvements in mental health and overall quality of life, as well as decreasing long-term disabilities. But these are more theoretical, mostly not evaluated in the randomized trials of the implementation studies. There are also a number of contextual considerations that are important. As we've already talked about at length, the prediabetes prevalence is increasing, and clearly this is a huge public health issue for our country. Culturally appropriate interventions also may decrease some of the disparities that Dr. Shore highlighted earlier, where certain groups have a higher prevalence of both obesity and prediabetes, and I've listed some of those groups here. So in summary, for the in-person group counseling, the overall rating for the evidence was a B+, which means evidence that the benefits are incremental or better net health benefits compared to usual care. This was primarily based on the large number of trials, the background of the large randomized trials, clear weight loss outcomes at 1 year, and evidence that the benefits in terms of glycemic control were similar to those seen in the DPP. For the digital human coach programs, the evidence rating was the same. For the digital fully automated program, we gave this a C+, so comparable or better net health benefits compared to usual care, primarily due to greater uncertainty. There was only one trial in this space. It was a good quality trial, but only one trial with only 6-month outcomes reported. And finally, because of the lack of head-to-head trials and the fact that most of these approaches did not have a comparable placebo group, we couldn't do a meta-analysis or even a network meta-analysis to do indirect comparisons to distinguish among these three approaches. So there's insufficient evidence to distinguish among the three approaches. Finally, we received a number of public comments. The first comment was that there's uncertainty about the strength of the evidence because the implementation programs haven't reported on a reduction in the incidence of diabetes. We hope we've highlighted that enough, but we also felt like the evidence from the larger randomized trials was convincing enough that weight loss was an appropriate surrogate outcome. We also received reports about the heterogeneity of the background of the health coaches, ranging from lay people to trained health educators, and that this may influence the outcomes. Again, there's very little data to distinguish among these, but it's an important consideration. The comment that the DPP trial may really reflect a delay in the diagnosis rather than a prevention of type 2 diabetes. We integrated that both into the report and the presentation today, and certainly agree with that comment. We were encouraged to include some of the epidemiologic associations between obesity and both diabetes and prediabetes, which we've now included in the full final report. And finally, we received some criticism in our reporting of the pre-diabetes controversy. We did specifically quote one article which talks about pre-diabetes as a risk factor for a risk factor, meaning prediabetes itself is not truly a disease, and the primary health outcomes associated with diabetes are strokes, heart attacks, blindness, kidney disease, and so on, and that the feeling of some of the commentators was that that there are potential downsides to the label of prediabetes. The WHO also is concerned about the label of prediabetes. So we just wanted to make sure that the point of highlighting this was to make sure that the controversies in the field are fully aired for discussion here today, and we didn't intend to be taking a position on this. And with that, we'll turn it to Dr. Chapman for the economic evaluation. Thank you.
Thank you, Jeff. I'm Rick Chapman, Director of Health Economics for ICER, and I'll be talking today about some of the evidence on the cost effectiveness and potential budget impact of diabetes prevention programs. I have no conflicts of interest to report. So similar to the clinical evidence review, we reviewed the published literature for analyses of the economic impact of diabetes prevention programs in the U.S., and we restricted to programs with full or pending recognition from CDC's Diabetes Prevention Recognition Program. We included studies of the cost of DPPs, analyses of the costs that potentially offset through the use of such programs, such as through reduced downstream medical cost, and any cost effectiveness analyses that were published or publicly available. We found one review of cost effectiveness analyses for DPP programs by Lee et al. In 2015. This was an update of an earlier review. And this was a review of programs that were looking at diet and physical activity promotion delivered to persons at increased risk of type 2 diabetes. So this is a little broader than our review, which looked at only programs that had been recognized through the CDC DPRP. They found 22 studies in total. 8 of those were based in the US. And of those 8, the median cost per quality adjusted life year, or QALY, was around $9,800. They had an interquartile range from $1,930 up to $41,900 per QALY gained. However, it should be noted that few studies included information on recruitment cost or the cost to implement and scale these types of programs. In looking at the cost effectiveness of specific types of programs, There are several studies that have looked at in-person individual coaching. Most of these studies are based on the DPP trial and follow-up from that trial, and were conducted by the DPP research group. Those studies have tended to find that the cost per QALY for these programs will decrease as the time horizon for the analysis increased. So the original study looking at the DPP trial itself, which was 3 years in duration, found a cost effectiveness of $32,000 per QALY. There was also a study that looked at the DPP trial and the follow-up DPP outcomes study, which took the same cohort out to 10 years, and at 10 years found a cost effectiveness of $13,000 per QALY. They also took the data from the DPP trial and extrapolated that to a lifetime horizon, assuming similar effectiveness, that the 3-year effectiveness was carried forward, and that the program cost would be carried forward until the patients had incidence of diabetes. And in that lifetime horizon, they found that the cost effectiveness was estimated to be even lower, around $1,100 per QALY. There was one other study which looked at the DPP trial results and attempted to estimate the cost effectiveness using a different type of model. Most of the studies that we've talked about earlier used Markov cost effectiveness models. This used a model called Archimedes, which is developed to try to simulate the physiological processes in the human body. And when they did an estimate with a 30-year time horizon, they came up with an estimate of $143,000 per QALY gained. There are some differences between this study and the studies we were just discussing, which may account for these differences in cost per QALY estimates. Some of the primary differences are an assumed clinical benefits of DPP. As I mentioned, the DPP research group tended to have those continuing over time. The Archimedes study by Eddy et al. Assumed that these clinical benefits would diminish over time. The Archimedes analysis also took more of a health plan perspective, so they also accounted for participant turnover, patients who may exit programs. And finally, one of the bigger changes or differences that probably accounted for the difference in cost effectiveness was an assumed lower rate of glycemic progression. So that was slower progression from both prediabetes to diabetes and from diabetes diagnosis to complications. And by assuming that slower progression in this study compared to the others, the cost effectiveness was increased. There have been a few studies looking at the cost effectiveness of in-person DPPs with group coaching. Several of those, again, were done by the DPP research group based on the DPP trial results. And it's important to note that here, when they're looking at a group intervention, they weren't actually studying group intervention. They were making an assumption that they could provide the group intervention similar to the DPP trial's curriculum to patients, and that this would reduce the cost without reducing the effectiveness. So they assumed equal effectiveness for this program delivered in a group setting. And as we've seen from some of the evidence presented by Dr. Tice, that's probably a reasonable assumption. When you make those assumptions and do the analysis at 3 years, the cost effectiveness came in at $9,000 per QALY. At 10 years, it's reduced to $1,500 per QALY. And when they projected out to a lifetime horizon, they actually found that the intervention would be estimated as cost saving over time. The Archimedes model did a similar analysis looking at group coaching at a 30-year time horizon, and they found that cost per QALY was also greatly reduced from their base case, which looked at individual coaching, with an estimate of $27,000 per QALY for a 30-year time horizon. There have been some studies looking at the YUSA's implementation of the DPP, which again is a group-coached implementation. Claims analysis found that the program was actually cost-saving at 2 years' time. And recent Medicare budget impact analysis projected out to a lifetime horizon and found that these programs would be cost-saving for the Medicare program. There's less evidence on digital provided DPPs. For digital human coaching, there are 2 studies out there. There's a return on investment analysis for the OMADA program, which estimated that the program would be cost-saving over a 10-year time horizon. And there's also been a cost-effectiveness analysis of the Canary Health VLM program with a 10-year time horizon, which estimated about $7,800 per QALY. We were not able to find any published cost-effectiveness analyses on the digital fully automated program. So in summary, economic analysis seemed to be pretty consistent that DP programs are cost-effective or even cost-saving over time, especially when they're provided in a group setting or as a digital program with human coaching. All of the estimates we found in the literature were less than $50,000 per QALY, except for one, which was the Eddy et al. Study using the Archimedes model, and that was still less than $150,000 per QALY. However, the evidence is more robust for in-person DPPs. There are fewer studies of shorter duration for digital human-coached programs, and as I just mentioned, there are no published economic analyses for digital fully automated programs. We received some public comments on our review of the cost-effectiveness analysis. First, there was a concern that we were not being consistent with prior reports because while we summarized the literature on cost-effectiveness analysis, we had not developed our own model looking at the cost-effectiveness of DPP programs. However, in the past, for these types of programmatic topics such as behavioral health integration and palliative care, this tends to be our approach. We look at the review of the literature rather than developing our own model. In this case especially, we thought the literature was relatively robust where there was good evidence, and where there was not good evidence, it would be difficult to develop our own model on cost effectiveness. We also had a request to add a direct question about cost effectiveness to our voting questions. Again, this is not something we typically do for a couple of reasons. First, there's no really commonly agreed upon single cost effectiveness threshold in use in the United States. And secondly, we include cost effectiveness as one part of our care value votes rather than singling it out for a separate vote. And finally, there was a suggestion to include a study on the cost effectiveness of intensive individual coaching that had been published in 2012. We had examined this study. We did not include it here because while it did look at cost per case, or cost of, or rather not looking at cost per case prevented, it was looking at the number of cases that would need to be prevented, of diabetes cases that would need to be prevented to make a program cost-saving or cost-effective. So it did not actually produce cost-effectiveness ratios as part of the publication. So we were not able to include that in our review. We also went on to look at the potential budget impact for the United States of implementing these programs over 5 years. To do that, we looked at published or publicly available information on program cost, any cost offsets, and the size of the potential population eligible for these services. And it's important to note here that we're looking at the total net cost. So this is the incremental healthcare cost of implementing these programs minus any healthcare costs that were offset through delayed diabetes prevention or other cost offsets. We estimated the potential population that would be eligible for these services. Again, we're looking at adults age 18 and older with prediabetes. If we use the impaired fasting glucose threshold that we've heard earlier of 100 milligrams per deciliter, that's about 93.7 million individuals in the U.S. Just in contrast, if we used the alternative definition, which we've heard about, of 100 to 124 milligrams per deciliter, that number would drop to around 31 million patients, so quite a big difference. For those 93.7 million, we realized that it's not feasible for all of those patients to be enrolled in these types of programs over a 5-year time horizon. Here we assumed that 10% of patients would gradually enroll in these programs over a 5-year time horizon. So that means that the 2% per year. So in year 1, 2% of these eligible patients would enroll, 4% in year 2, and so on until we reach 10% at 5 years. So for year 5 treated estimates, that would imply about 9.4 million patients being enrolled in these types of programs. This table shows the results of our potential budget impact at 5 years. For in-person individual coaching, with about 9.4 million individuals enrolled, you can see the weighted budget impact per participant would be around $2,800. And this is weighted by the amount of time each person is in the program. So persons who enroll in year 1 get 5 years of cost and benefits, while persons who enroll in year 5 have only 1 year of cost and benefits included here. And if you look at that over the 5 years, the average budget impact per year comes out to about $5.2 million, or billion dollars, sorry. For in-person group coaching, in contrast, here we actually estimated that the programs would be cost-saving over a 5-year time horizon, weighted budget impact per participant of a little over $1,000 per patient, and the average budget impact per year would be a savings of about $2.1 billion. And then for digital human coaching, similar results in terms of being cost-saving, although the magnitude was smaller, about $620 per individual, and over a 5-year time horizon, the average budget impact per year of a little over $1 billion. I will note that there were no published or publicly presented data available for digital fully automated programs. We did look at some unpublished data that had been provided and found that these programs are likely to be cost-saving, although it's difficult to determine the magnitude of that cost savings without more complete data. We received one public comment on our budget impact analysis, and that was in relation to our presentation of the digital automated results. We had originally presented this based on HbA1c results from one program. We were given additional data using fasting blood glucose rather than HbA1c results to look at reductions in diabetes incidence. Again, this was from one small unpublished study, and so we do present the results of this part of the analysis as a scenario analysis, but we don't include it in our full results, tabular results. Thank you.
Thank you, Rick. Now we have an opportunity for the panel to raise questions of our 3 presenters, as well as discuss some of the implications. And I would like to invite Dr. Elizabeth Murphy and Dr. Ann Albright to the head table to participate in this Q&A and discussion. Yes, Dr. Redberg.
Thanks, Dan. So I have some questions, maybe for Jeff for the evidence review or for any of the panelists. But one, it strikes me, sort of a broad question or comment. Couldn't we just substitute obesity for prediabetes? I mean, I'm not sure why we're doing all this testing, because all of the trials are really, the outcomes are weight loss. And we know even if you're not pre-diabetic by your impaired fasting glucose, obesity has a lot of adverse health effects. And it just seems to me that we're spending a lot of time and energy and money on testing that we could just put people on a scale and decide whether they would benefit from a diet and weight loss program.
I mean, none of the trials really looked at that. It's a little hard to say whether that would be appropriate. I mean, in terms of the health benefits for those folks, I mean, I think we know from the bariatric surgery literature that, you know, the biggest health benefits, gains in terms of longevity and improvements in health outcomes come among diabetics. So that's probably why we're focusing on that, because there are so many adverse health effects of diabetes. And there are certainly some people with obesity who don't have metabolic complications, and so that may not be an appropriate use of resources for those patients. And it looks like maybe one of our experts has more to say on that. I mean, certainly none of the trials looked at that. It's very hard to comment. We didn't look specifically at just weight loss interventions for patients with obesity or in the overweight category and look at the effects on health outcomes.
Dr. Melnikoff.
This is on. I have a question for Jeff and then one for Rick about the cost effectiveness analyses. But you said this, but it went by quickly. So the definitions of pre-diabetes, the two different definitions, lead to different rates of progression to diabetes in the population. Is that right?
Thanks.
That's correct. So
okay.
the absolute incidence would be.
So the higher threshold results in what kind of percentage of progression?
Again, it would vary within the definitions, but up to 10% or so, 10 to 13% per year progression to
per
diabetes.
Year. And then the lower or the
was on 2 to 3%. I mean, again, around 2%, I think, for 100 to 104, 105 to 109, and it starts getting closer to 3%. Our experts may know that literature even better than I do.
So then it seems like depending on the definition that's used for people to get into these programs, you have the potential to show a greater or smaller effect on the progression to diabetes. Would that be?
Right. We don't have great data on whether the relative efficacy changes. The data, I think, suggests that the relative efficacy would be similar, but the absolute risk reduction and thus the translation into cost effectiveness would be much greater in the folks at higher risk for progression than those at lower risk for progression.
So that kind of leads to my question for Rick, which is taking into consideration the fact that, if you have a greater absolute risk of diabetes progression and if it's delayed, right, it doesn't seem like it's actually prevented indefinitely. Did you look at among these different programs whether the cost effectiveness seemed to vary by who got into the programs in the first place?
We didn't find a lot of evidence that looked at that. We do present in the report analyses looking at the budget impact analysis for a 110 milligram per deciliter group. But it's important to note the only thing we were really varying there was the number of patients. We were not varying the effectiveness of the programs. So to the extent that there is some differential absolute rates in the absolute rates of prevention, there would be presumably even more cost effective for those 110 to 124 patients.
And then if I understand it correctly, in the DPP, which had the longest follow-up, right, after some period of time, like 10 years, they actually had quite a number of people that did progress to diabetes. And so, is that right?
Yeah, at 15 years, it was 55%.
Okay. So in the cost effectiveness analyses where they're projecting out what's happening, did they project that this increasing percentage of people would develop frank diabetes, or did they take the 3-year rate and just sort of push that forward to lifetime or whatever longer horizon?
Yeah, I believe there was 3 years, and then there was also a 10-year follow-up in the DPP-OS. And then when they project that forward, I believe what they're doing is taking the same rate of delay or in diabetes incidence and projecting that forward. So
they're sort of pushing that out to be an indefinite rate, even though the rate actually goes up with time.
It's important to note, though, they're also assuming that the program continues over time.
Right, so it's sort of an optimistic estimate, it seems like.
Yeah, I think you could call it that.
Okay, thanks.
Dr. Murphy, would you state your title and any conflict of interest before you speak, please?
Sure. I'm Elizabeth Murphy. I'm a professor of clinical medicine at UCSF, and I have no conflicts to report.
Thank you.
And I just wanted to go back to Rita's question. I think we both wanted to comment a little bit more on that. There are a lot of other things that obesity is a risk factor for, and I don't think we have as much data on prevention of those, which is probably part of the issue. But the other thing is not everyone who is obese is at increased risk for diabetes. There are a group of metabolically fit patients out there, and while every patient I see tries to convince me they are one of those, and the majority are not, it is important to remember that obesity per se isn't the only risk factor for the development of diabetes. I think Ann had more to say as well.
Right, but diabetes isn't the only health problem in the world either.
Exactly.
Hi, I'm Ann Albright. I'm the director of the Diabetes Division at the CDC, and I have no conflicts.
Thank you.
We did an analysis, a cost-effective analysis of the 2 USPSTF recommendations, one for obesity counseling and one for the CVD risk reduction. The CVD risk reduction we haven't published yet, but our findings show that when you look at the specific individual CVD risk factors, until you have the overweight or obese, and particularly obese, when you add the glycemic issue, you move the farthest into cost savings. Even if it's just the lipids alone or just hypertension with the overweight or obesity, you really get a much better cost effectiveness or cost saving argument when the glycemic issue is added. So you're right, you're talking to people today who are related to diabetes, but I think there are other options and opportunities for people who are only overweight. There is a USPSTF recommendation, and there is the obesity benefit now covered by CMS. So that is in existence, but it has not been sufficient for those with pre-diabetes.
Related to that, in the DPP trial with the 15-year follow-up and the people that got diabetes, how many of those maintained their weight loss as opposed to had gained weight in that time period?
I don't recall the exact details of that. I should say one other thing, too, which I neglected to mention, related to the long-term follow-up of the DPP. At 3 years, those who were not in the weren't in the lifestyle arm were actually offered the lifestyle intervention, and 60 to 70% of them, I think, elected to go through the full lifestyle intervention. So that sort of diminished differences between the two groups. But definitely there was weight regain. As we all know, that's a problem after any weight loss. And I just can't remember the details. I'd have to go back and,
right,
and
I'm
look
just
at that.
curious whether the diabetes incidence was correlated to gaining weight. And I have 2 more questions. In the, I guess it's slide, well, it doesn't really matter, 29, but in the DPP trial, or it seemed like most of them looked at % weight loss, is that a better indicator than the absolute amount of weight lost? So obviously % weight loss would depend, it looked like the BMIs were different for all those different trials. Like, is just losing 5 pounds good, or do you have to have a 5 to 7% weight loss to get this kind of benefit, you think?
Go ahead.
I don't know that anyone has directly compared those, but I think just being in negative energy balance itself changes your metabolism. But for all the reasons that you said, I think most of the data shows it's the % rather than the absolute amount. And maybe the % is linked to a greater time in negative energy balance. I'm not sure.
And my last question for Rick, unless, Ann, did you want to say something?
I was going to say, it has been a more useful measure to talk about, but physiologically, I mean, there are people who do report it in pounds lost as opposed to %, but it tends to translate better for whether you're a 300-pound person. It may be that you've got again, the percentage loss is a more effective measure than saying, oh yeah, if a 300-pound person lost 5 pounds, that's going to have a metabolic impact.
Sure. I just, like, when I talk to my patients, I always tell them, set weight loss goals in numbers, not in %. But
yeah, we usually translate it. So in plain language, when we're putting out information to the public, we may say something like, for a 200-pound person, that's 10 pounds, so that it makes sense to people.
Right. And Rick, can you just give us a little more information on how the QALYs were calculated in that Lee study, I believe? Like, how did they translate those diabetes numbers into QALYs?
The Lee study was actually a review of published cost-effectiveness analyses. And I can't recall exactly the source of the quality of life weights that were used in most of the analyses we reviewed. As I mentioned, most of them did come from the DPP research group, and I can't recall if they actually measured that during the trial or if that was taken from the literature, but I can look that up and get that to you.
Can you clarify?
Ms. Kim.
Yeah, can you clarify, so the program is actually 1 year long, and then what happens in year 2, 3? I mean, I know we followed those patients, but was there any other intervention after that?
Excuse me, sorry. There were definitely, they were offered ongoing support and I think on a monthly basis for the continuation trials, both years 2 and 3, and then on going forward.
And that's included in the cost analysis?
Yes.
Yeah, they're considered what's known as booster doses, so it's not necessarily of, full-blown ongoing maintenance, but it was periodic touch bases and support.
Yes. Dr. Fox.
Thanks. I have a question about, mostly a clinical question about the delay in diagnosis or delay in onset as opposed to prevention. Wouldn't there still be a very high clinical benefit for having a delay in onset for the individual and then at the societal level? I mean, wouldn't that be the case for any chronic progressive disease, that a delay in diagnosis, or I should say delay in onset, even by a few years, would have a big impact?
Yes.
I mean, prevention would be better, but it still seems that, especially when we're talking about these numbers, that a delay in onset of a few years would still translate into a big benefit.
Yes, there's no question. I mean, again, talk to any of us who live with diabetes, and we can tell you it is a burden. It is difficult to live with this disease. And the more you can put it off, the more you can prevent people from having to contend with the threat of blindness and amputation and kidney failure, the monitoring that has to be done, the things that you have to do, the tests and exams, the burden on your family. The more you can prevent that, it's not only economic savings, but it is psychological, social, family, relationships, employment, all of that matters.
I will say, though, that hasn't fully been captured in the DPP results, and even at 15 years, they did not see a difference in either macrovascular or microvascular outcomes. In the Chinese trial, which is smaller and has a few more methodologic issues, there were differences in cardiovascular event rates at 20 years with this kind of delay in diagnosis.
So are you saying that for those who did not have a delay in onset, they had the same complications at 15 years for those who?
I'm saying if you compare the lifestyle intervention arm in the DPP trial to the placebo group, and you look at 15 years, there's no differences in onset of diabetic nephropathy, of retinopathy, and so on.
But keeping in mind what Jeff said before, they got the intervention. It was just delayed.
Right.
But there was a delay of 2 to 3 years, and we don't. So I think the delay in diagnosis definitely has implications in terms of labeling, anxiety, impacts on family, on testing, and so on. But in terms of clinical outcomes, we haven't seen that yet in the DPP trial, which I think is the most rigorous and most applicable to the U.S. population. Though there's ongoing follow-up, and the thinking is by 20 years maybe we'll see this, but it takes a long time.
Yeah, go ahead.
Thanks.
So my question has to do with, back to this question of kind of teasing out the impact of the obesity and prediabetes. Given that it seems to be the highest risk group are the people who have both, from putting together what everyone's saying. For the program itself, how much of the program is not specifically obesity related, but is about diabetes related, or is it pretty much all the content of the program focused on obesity. What I'm trying to say is there a marginal benefit to anything that isn't specifically directed at obesity in this program?
Right. I mean, I think it would be good to look at the, just the topics listed, that are in your packet there of what, and most of them were directed at exercise, diet, and behavior change, and not specifically at diabetes or prediabetes.
If you participate in any of these programs or listen in, I think where there is a difference is that the initial sessions do talk about the risk of diabetes and sort of begins the process. Again, these people, many of whom have articulated, again, wouldn't be captured necessarily in the studies, but in the practical implementation of this work, we do hear from these people that that diagnosis of prediabetes is what has motivated them. Many of these people have tried weight loss before, and this program has, and this diagnosis has prompted them to take action. So they are a group of people who are in problem solving together. But yeah, it's certainly relevant to issues around problem solving, coping, and the goal is to increase activity and weight loss.
Dr. Durbin.
I'd like to hear more about the longer-term aspects of the program after the initial parts, which I guess last about a year, because I don't think most of the studies outside of DPP actually include the longer-term follow-up. So you talked about booster sessions. I'm interested to know what those are like, what the dropout rates are that we know for that, the consistency of what those longer-term interventions are and how necessary they are, and whether it matters which modality the longer-term aspects of the programs are once they've ended the initial, more intensive parts of them. If those are critical to longer-term success, what do we know about them?
Yeah, I mean, I can speak to the DPP, the Daoqing, which my team at CDC has been involved in for many, many years. We help support the Daoqing. They are trials, and so that cohort is certainly being followed. And so there are lessons that we are learning. What they get, it depends on which of these studies. And over time, the booster sessions, they may become certainly less frequent. Most of what happens in these long-term, the 10-year now, is they're really just being followed. They're not in a program per se any longer. We have a lot of questions about what needs to happen after the year-long program. We will likely get to it later today on the policy table. Right now, we're involved in the rulemaking process with CMS, and there will be opportunities for us to look at the ability for people to stay in maintenance phase for longer than a year. My team is going to be looking at some of those issues too around what does it take? Is it a virtual session? Is it touching base periodically? And I'm sure some of our people in the audience who are running these programs will offer information as well. There's clearly, maybe I'll just quickly sum up. In the world of medication management, we do not stop giving people medication for a condition that they have. We don't give them half a dose, or we don't, so we need to think about this more in terms of that. There has to be some practical implementation for this. This is why the national DPP has been constructed. It's to give us in this country, for the first time ever, a distribution system for lifestyle. We have a distribution system for medication. We do not for lifestyle. So I think to directly answer your question, we need to better understand exactly what components those need to have, how often should these quote-unquote booster doses be given, and exactly what needs to be contained in them.
So the corollary to that is, how do we put that into the cost analyses of the long-term benefit of these programs if we're not sure what the ongoing efforts need to be, which of course, depending how intensive they are, have different costs. So how do we assess what the longer term benefits are going to be, not knowing how frequently and what modalities and who needs to deliver the ongoing interventions? What can you tell us, Rick?
Yeah, I think, it increases the uncertainty around the long-term cost effectiveness of these programs. We just don't really have the data right now to know what those need to be. We could, I guess, take make some assumptions around taking the 1-year cost, for example, and assume what if we took a full program and carried that forward. I don't think anybody's really suggesting doing that, but that would at least give us an upper limit on what that cost is likely to be.
Dr. Winslow.
In anticipation of the voting questions, I wanted to ask Rick or maybe Jeff or possibly Jed about the question on the care value of the fully automated programs. Rick, you mentioned more than once that there are no published data on the cost effectiveness of those programs, and yet one would think you'd have to take that into account to answer the question about the care value. You want to comment further on that, or anybody else want to?
Yeah, I think it's a good point. There's much more uncertainty around those types of programs. I think I will point out, though, that the cost for those programs is lower than the other programs. And to the extent that we've seen some effectiveness data, they do seem to be effective. So there haven't been any formal cost effectiveness analyses published yet, but you can maybe extrapolate from those.
Dr. Melnikow.
So just going back to follow up a little bit on this last discussion about maintenance and cost of maintenance. So in the existing published cost effectiveness analyses and the budget impact analysis, was the assumption that it was just the program for however long it lasted, a year, and then no additional costs to maintain the participants and that all the benefit would continue to roll forward, or was there some?
It was assuming kind of the maintenance dose, sort of the booster dose kind of program was continuing.
Okay, so there were costs incorporated into these analyses. Yeah. Okay, thanks.
Dr. Grisette.
This is related to the question regarding sort of how comparable are the digital solutions. And I was wondering if there's any basic data regarding adherence, because it's sort of one thing to be a person who's motivated to be in a clinical trial, and there's another person who's motivated enough to do a monthly program, and then there's another person that, you know, sort of wants to engage with an app. And since the long-term benefits seem to come from adherence to a program over a long period of time, do people adhere to the digital programs as well as with the in-person?
Yeah, I mean, that's a complex question. Certainly in the data from the trials of the digital programs, those who enrolled had comparable levels of completing 4 lessons, continuing on, and so on. But they're probably very different populations. For example, the Amada Health trial recruited solely online, and it was their average age was about 10 years younger than the other populations studied, probably reflecting the fact that these were patients who, the younger patients are more likely to engage with an internet-based, at least recruitment and so on. And that may impact adherence rates. We don't have, unfortunately, randomized trials comparing these different programs where you have the same kinds of people randomized to these 2 different trials and see whether, adherence rates are the same. In the DPP trial, they had remarkable adherence greater than 95%, but these were people who went through a number of, were willing to be randomized to either a drug or a lifestyle. So they're very different than people we're going to engage with in the real world. So it's very hard to really say anything meaningful about the comparative retention rates for these programs.
Dr. Redberg.
It strikes me, looking at a more global view, the U.S. has a much bigger obesity and diabetes problem than any other country in the world, and we spend a lot more on health care, and that there are other things that are influencing that we haven't really had any kind of discussion of, but there are a lot of, and you'd like to comment on them, but I made a short list, like we could spend money on more bike lanes or more sidewalks or more parks or, stop subsidizing.
For the policy roundtable, that's exactly what we'll be talking about.
Right, but in terms of talking of cost effectiveness, I think those are much more sort of cost effective if we want to discuss cost effectiveness than, soda tax. all these kind of things, and it just, I just couldn't help when Rick shows, $5 billion would be the budgetary impact. I mean, you take that and give it, that's a lot bigger than the CDC's budget, which is supposed to be our premier, public health agency. What could we do with that kind of money?
You don't have to answer that, Anne.
We'd love to talk about that this afternoon. In fact, I think we must talk about that because it's a critical part of the discussion. They're not mutually exclusive.
And the only thing I'll add is that it's a misperception that we have the biggest burden, certainly in terms of absolute numbers of people with diabetes. China and India have a huge problem. They exceed us, and those are countries where patients self-pay for medications often. So the burden in those countries
I said obesity was highest in the U.S.
Okay. But they're linked.
And that it's changed over 40 years. So clearly it's not our healthcare system that it was environmental.
No, I agree with the environmental thing. It's just it's a worldwide problem.
I'm focused on obesity, but thank you.
Dr. Castano.
There's a third player in this obesity, diabetes, pre-diabetes interplay, which is depression. And did the DPP address that or assess for that? And do you have any comments about the role of a program like this as a depression treatment, and that perhaps that is the underlying effectiveness of something like these types of programs?
Comment? Any comments?
I can just comment from a purely case-based clinical perspective what an important factor that is. We've just started a new obesity clinic in our public health hospital in San Francisco General, and it is such a huge factor, but I don't know how well and easily it is to study the role of this in that, but it is a huge component of this.
They did assess quality of life issues in the DPP, and we can certainly follow up and get you more details about that. But it is a significant part of this work because it's important that people have the opportunity to address those. Whether or not it addressed depression per se, I think that would still be up for discussion.
Just to keep us on schedule, Dr. Fox has a question, and then we will allow one more question after that. So would you go ahead, Rena? Thank you.
I think that the digital programs, although they're very, it's easy to understand why they would be more scalable to a large population. Aren't there also data about increased screen time, at least in children, correlating to weight gain or obesity? And it feels a little bit ironic to me that we would be mass producing digital programs which are increasing sedentary screen time, although it's more scalable.
Yeah, I mean, again, if just a couple of quick comments. Yes, you could say that is an issue. I guess many look at it as, how about if we use the screen time people are engaging in for better purposes? Because this is basically an hour a week and then an hour a month or so with potential people revisiting on a screen if they wanted to. I just would also like to quickly add, and this may come up in the policy discussion this afternoon as well, yes, we can and maybe we should do head-to-head trials between in-person and virtual. If we can match everybody for every single thing you'd need to match for. But as was pointed out, people have different preferences, and you've really got to, in the real practical implementation of this stuff, you've got to be very attentive to preferences. And behavioral economics demonstrates to us that, yeah, we don't want to overwhelm people with choice because then they just sort of get paralyzed and don't make any choice. But to require that everybody either do an in-person or they do only a virtual is not going to get us where we need to go. So our perspective is that we need to maximize each of these modalities and make them the very best they can be, and then be sure that people get access to what is going to meet their needs. We're not asking for 9,000 choices. It's again why the National DPP is trying to really harmonize and unify this work together so we can actually really be pointed at the bullseye instead of everybody running all over the place with umpteen kinds of programs with very questionable outcomes.
Dr. Steinberg, the penultimate question in this session.
What's that? For Rick. a lingering question in my mind, and I wonder if you could speak to this.
Speak louder.
Is there a on here? It's on. Yeah. Talking closer into it. There we go. Sorry. For Rick, a lingering question in my mind, and I wonder if you can speak to it. With the definitional issue in terms of entry into the studies that you looked at, how much is that a confounder in your cost effectiveness type results and analysis? How certain are we about those numbers at this point?
You're talking about the 100 versus 110 criteria?
Yeah, and the difference in conversion, the glycemic conversion.
Most studies, unfortunately, have really used one threshold and haven't really looked at what would happen if you split that out by the different thresholds. I believe there may be one study that looked at using different A1C thresholds to screen and identify patients. They did find that, of course, the more specific you get and the more rigorous the criteria is to get in, the bigger effectiveness you're going to have. So you're going to get better cost effectiveness ratios. I don't recall right now exactly what those ratios were, but the more rigorous you make that, the more cost effective you're going to get because you're having a bigger bang for the buck, in other words.
Bob Collier gets the last question in this section.
Are we interrupting public comments?
I'm sorry?
Are we interrupting any public comments? Because I don't want to do that. There's nobody else going to ask questions there from the audience? We're getting to that in a minute, right? Okay. I come from the cancer world, and we've been talking about prevention for a long damn time, and it's kind of really doesn't go very far very fast, obviously. But to add on to Bob's, that 100 to 109 is unnecessary biopsies in our world. And I hate to be so blunt about it back that, but that's really what it amounts to, and when we've had big discussions about that stuff. I'm really interested in trying to get back to prediabetes here from this particular point of view here, because there's no definition for this, really. We've got to pin it down to some measurement, but all of our measurements are surrogates, because what we're trying to do is label something, as Jeff did earlier, a health condition. It's not a diagnosis. I get it that the prevention program needs to come in here somewhere. I'm all for CDCs and getting some kind of prevention program off the ground here. But I think we need to speak something. I wish somebody would speak more directly to what is prediabetes, and are we going to actually really make it something here? And how is this really going to work from the primary care office, where these things that we're talking about here today are clearly superior to just your doc saying you need to lose some weight, and here's a sheet of proposed exercises for you. There's a place where you can look up some dietary advice. This is all clearly superior to it. We've got evidence here that shows this. Anyway, if you'd speak to that, I'd really appreciate it. And on the end of it there, I will, obviously, I'll cop to it. I'm morbidly obese, but my A1C is fine. It always has been. And for the foreseeable future, it will be, of course. But when it crosses the line, and just for a tidbit here, how often do we go back? If your A1C comes down again and you're out of the program, but it goes up again 3 years later, what are we going to do with that? Are we going to pay for this over and over again?
You're highlighting one of the issues we will ask Lisa about later to educate us all a little bit more about glucose metabolism. So thank you.
Proceed to the next section, which is public comment. And we have two speakers who wish to address us. Their time will be limited to 5 minutes. And would you kindly announce your title and any conflict of interest? The first speaker is Dr. Bruce Wolfe.
Thank you. I'm Bruce Wolfe, professor of surgery at Oregon Health and Science University. The only potential conflict is that I am past president of the American Society of bariatric and metabolic surgery. We understand that a review of surgery is not the intent of the present report, but have concern regarding the implications of the report, which would lead the reader to believe that lifestyle intervention is the only intervention which might be done to prevent the progression to diabetes. Dr. Tice nicely showed the relationship of weight loss to the delay or prevention of progress. The ICER report that was referred to earlier from August of last year states that surgery outperforms all medical treatments in sustained weight loss. So we believe that addition of a comment in the introduction referring to the prior ICER report would give balance and perspective to the present report. Thank you. Any questions?
Thank you very much. In this section, we just allow the comment without any dialogue. So our next speaker is Jean Kunde. I hope I'm pronouncing your name properly.
You are.
Thank you. Thank you.
My name is Jean Kunde. I'm the CEO of an organization called Diabetes Hands Foundation. We're a nonprofit that's involved in providing information, education, and support to people in the diabetes community. And in full disclosure, we receive our funding from grantors, corporations, some of which are involved in the diabetes sector, and individuals through donations. Okay? I'm here today on behalf of the Diabetes Advocacy Alliance, which we are a member of. That is a coalition of 21 diverse members who are all concerned about this issue, and we appreciate the opportunity to provide a public statement related to the Diabetes Prevention Program's Effectiveness and Value Evidence Report that was released on June 6th. Overall, the DAA, Diabetes Advocates Alliance, supports ICER's review of diabetes prevention programs and its findings that DPPs are effective at preventing or delaying the onset of type 2 diabetes. We also support ICER's findings that DPPs, particularly in-person group and digital human coached programs, are cost-effective and cost savings over time. Comment on characterization of prediabetes and diabetes. There's been much of this shared this morning. While the DAA understands that ICER in its report was referencing controversies in the literature regarding the term prediabetes, the DAA is opposed to language that downplays the seriousness of the disease. For example, the evidence report states that critics of the term prediabetes have raised concerns about the adverse effects of labeling patients, giving those with prediabetes are at high risk for diabetes, but do not yet have been diagnosed disease. 2014 criticism published asserted that prediabetes could be defined as a risk factor for developing a risk factor. As previously stated, for nearly 30 million Americans living with diabetes, the disease is simply not a risk factor for developing a risk factor. Diabetes is, in fact, a serious and life-threatening condition that impacts the daily lives of people with diabetes, as well as the lives of their loved ones. Diabetes is a very complex, chronic disease that requires daily decisions about how to manage one's glucose levels. Without proper management, diabetes can lead to devastating and costly complications, including but not limited to stroke, heart attack, blindness, kidney failure, and death. In downplaying the seriousness of diabetes and the diabetes epidemic, critics do a huge disservice to public health efforts to prevent, manage, and treat this devastating disease. In addition to the tens of millions of people who already have diabetes, as we've heard here today, those that live and manage their disease every day, there are 86 million Americans with prediabetes who are at risk for developing the disease without intervention. The diabetes epidemic, which includes diabetes and prediabetes, costs our nation $322 billion per year. In the evidence report, ICER refers to critics who've raised concerns about labeling patients with prediabetes. The DAA would like to point out, as referred to in the evidence report, the Center for Medicare and Medicaid Innovation found improved health outcomes and significant cost savings accrued when individuals with prediabetes participated in a DPP through the YMC of the USA. it's difficult to understand what kind of adverse effects result from targeting individuals with prediabetes and enrolling them in DPPs when the outcomes are improved health and reduced health spending. Further, new guidelines for screening for abnormal blood glucose and type 2 diabetes released by the United States Preventive Services Task Force in October 2015 found no long-term psychological harms associated with measuring blood glucose, and also that the harms of lifestyle intervention to reduce the incidence of diabetes are small to none. The DAA encourages all stakeholders to emphasize the seriousness of both prediabetes and diabetes in an effort to stop this epidemic. In closing, we'd also like to suggest that the panel vote for a high care value rating on this issue. Thank you for considering the Diabetes Advocacy Alliance's comments and providing me with this opportunity to represent the coalition today. Diabetes prevention programs are effective at preventing and/or delaying the onset of type 2 diabetes and have the potential to change the trajectory of the diabetes epidemic in the United States. The Diabetes Advocacy Alliance fully supports expanded access and coverage for this critically important preventive service. Thank you.
Thank you, Mr. Kunde. Having heard our two public commenters, does the panel have any questions or comments on the two public commenters or what they said? Hearing none, we will move on next to our vendor public comments. We have 5, and I think the best way to do this one is after each 5-minute or less presentation, if you have questions, we'll ask the question right after the comment. Our first commenter is Sean Duffy from Omada. Mr. Duffy. Morning.
Hello. So my conflict is that I am the CEO of Omada Health.
Welcome.
Oh, yes, I'm too tall. So I'm Sean Duffy, co-founder and CEO of Omada Health. We are one of the earliest and now the biggest digital plus human coaching DPP providers, and it's an honor to be here. Firstly, I'd like to thank CTAF for conducting this thorough and thoughtful report. This is truly an incredible contribution to the space. It is work that needed to be done. It is hard work, and the timing is fabulous for a number of reasons. The first is, over the last 5 years, the critical foundations of the CDC's National Diabetes Prevention Program have been laid. Guidelines are in alignment that these programs should be offered as first line for people at high risk for diabetes, and seniors across America have just learned that Medicare is designing a DPP benefit for them. All of those things together means that no doubt we are at a tipping point. The voting question asks to contrast DPP against usual care. So I'd like to share a story about what usual care feels like. 5 years ago, while still enrolled in medical school, but before writing a single line of software for Omada, my co-founder and I traveled to rural Georgia to sit with people with prediabetes in their living rooms. We wanted to find out what they were offered to help avoid the disease. The people we talked to felt abandoned. After finding out that they were at high risk for a disease, at best they were handed a pamphlet and told to change their lifestyle and lose weight. On their own, with no social support or ongoing guidance, that was it. Imagine that for a moment. Imagine being told you are literally scheduled to progress to a disease that would affect aspects of your life, but imagine you didn't have any idea where you could turn to for help and support. And imagine knowing that your physician felt equally powerless to get you into a program, because as a physician, you hand that pamphlet over, but deep down, you know the odds of success are low. So that was 5 years ago, and despite progress, this is still the standard of usual care for the overwhelming majority of people. At Omada, we're immensely proud that we've now enrolled over 60,000 people into our program, but we and the whole diabetes prevention community at large know the work is just getting started. As noted in the CTAF report, commercial adoption lags behind guidelines and the obvious need. On the whole, we found the evidence review in the report to be thorough, thoughtful, and we agree with its ultimate conclusions. We did, however, wonder why digital was found to have a higher budget impact in year 1 and 2 given similar clinical effectiveness. This point has the potential to discourage commercial payers with higher churn and short payback periods from offering a full range of DPP options to their membership. However, we concur that the evidence supports a B+ recommendation for both in-person and digital plus human coaching. and our 7.4 million weight readings across our 60,000 plus enrollees align with our peer-reviewed results. In fact, just this morning, before 9 a.m., as everyone was gathering their things heading to the event here today, 23,700 participants in OMADA program stepped on their scales, weighed in, and showed participation in the program. We also agree that the evidence shows both in-person DPP and digital plus human coaching to be cost-effective or cost savings. This report and the evidence-based rating will not be the end of our clinical publishing at OMADA. We consider the rating a foundation, a standard with which we will continue to justify with evidence generation and the publication of peer-reviewed results. 2 points in the report rang especially true and brought me back to the days where I was with people with prediabetes in their living rooms in Georgia. It highlighted that in low-income communities, where the burden of diabetes is often greatest, that not having a close DPP location, access to childcare, or transportation capabilities are immense barriers. In California, the report noted that the rates of prediabetes are higher in the Central Valley, but relatively few DPPs have been located there. These factors are why access to both digital plus human coaching programs and in-person programs are mission critical. I'd like to close with something I found surprisingly interesting in the report, which was actually in an appendix, Appendix D. In Appendix D, CTAF reviewed 11 clinical guidelines to evaluate their stance on DPP or DPP-inspired or based programs. The ADA, the AHA, the AACE, ACE, NICE, the USPSTF, and 5 other respected organizations unanimously support that patients at risk of diabetes should be referred into intensive lifestyle interventions as first line. I found this to be remarkable. There is fabulous alignment by a diverse group of medical societies that do not always agree, yet there remains a mile-wide gap between usual care as it exists today and the implementation of these guideline recommendations. It is for this reason and for this gap that I think the magnitude of the benefit for both in-person and digital plus human DPP is high relative to usual care. Today is an important day. This is being watched by payers, providers, and patients. This is a moment that can serve as a tipping point for how we as a country give people at risk of diabetes the best possible support to delay or avoid the progression to the disease. The review of the evidence and the vote today are momentous because they're a chance to not only validate a clinical intervention, but validate approaches to scaling the intervention to meet the massive and complex need. This meeting here is a chance to make a difference, and thank you for allowing me to share my perspective.
Thank you, Ms. Jeffy. I have 2 questions.
Sure.
How long has OMADA been in the business?
We incorporated in 2011, so 5 years.
5 years. My question is, with 60,000 enrolled, you have a rich trove of information. What sort of priority do you place on publication of your data so that those of us who are struggling in this area to understand what happens over time can get some more information about what happens to these patients?
Priority number 1. Our first pillar at OMADA, we talk about this, it's written in our office, is we start with science. Which is why before building anything at all, we surveyed the literature, we got on PubMed, we looked at where the literature was strongest in prevention, it led us to DPP. The research that's been reviewed in the report is 1-year data, yet the report did note that we have now published peer-reviewed 2-year data, demonstrating durability up to 2 years. We plan to publish 3-year data. We currently have 2,300 participants now past the 2-year mark and are monitoring the data at all times. So we plan to be a key contributor in not only showing what can be done long-term, but ideally innovating around what can be done post-year 1, because digital affords the ability to stay with people in perhaps a bit different of a way, because you're not asking them to drive into a center, to re-participate, to commit to showing up somewhere. You have the ability to reach out to them in something that's a little bit more
And you
fluid.
have the ability to monitor their contact through the electronic media to your program, and how many people stay with the program, how many drop out. Do you have all of these data?
Yeah, we do, and Dr. Tice kind of mentions as much from the study, but our attrition rates are quite typical and quite in alignment with the brick and mortar implementations. Of note, this is more relevant to commercial communities, but we actually are outcomes-based pricing. So if people drop out, we don't pretend that they've completed. We do not charge.
Wait, I'm sorry, what did you say? That last
Our payments are based on outcomes, real meaningful weight loss outcomes. So if we are not able to capture that outcome through the median of 3 weight readings collected from a cellular scale in the person's home, we don't bill as if we're getting the outcome.
Gregory.
So can you confirm that you know, in fact, not only that they're losing weight, but they're also not becoming diabetic?
The trials that we have run have included hemoglobin A1C that was presented in the ICER report. As part of a commercial deployment, screening and monitoring of weight of glucose readings is not part of standard operating procedure because of the immense complexity and cost in doing so. So our published data do show A1C reduction.
And then is all of the interaction you to the consumer, or is there an opportunity for them to interact back to you?
The way that it works is actually quite similar to a brick and mortar program. We take people at risk. We actually match them into small social groups based on location first, so that you're with other people that are in your same world. So if you're in Louisiana, you're with other people in Louisiana, it feels a bit more rich. From there, we mail people a scale that has a cell phone chip in it, so we can get verified and validated weight data back without having them to pair it with their phone or their Wi-Fi network. And then we bring them into a group with a coach that's trained according to the DTAC standards. And the interaction happens at the group level between the person and the coach. So there's both kind of a peer component and then a coach-to-person component.
Okay, I think in fairness to Dr. Malnikow, do you want to ask one last question?
Remember, we'll have
and then we'll move ahead.
additional people
Thank
to
you.
bring these
This
things
is
out.
a quick question.
Sure.
Is your program available in any language other than English?
We have a Spanish translation. We actually partnered with the California Healthcare Foundation to build out both a low literacy curriculum, a Spanish translation with bilingual health coaches, as well as making sure that our mobile apps have feature parity with the web apps because mobile penetration is higher and underserved. We've also kicked off a clinical study that was in the ICER report as studies in progress that we call Prevent for Underserved Participants, PUP. 3 study sites referring safety net members into our program so that we can publish at least year-long clinical effectiveness of our program in that population with those changes.
Thank you very much. Our next speaker is Dr. Adam Kaufman.
Hello, good morning. Thank you for the opportunity. I'm Adam Kaufman, President and CEO of Canary Health. Want to thank you for the work you did. Here's my bound copy of the report that I have with me, and for the opportunity to speak and share a little more about our experience with diabetes prevention. My conflict of interest is I'm President and CEO of Canary Health. So first, again, thank you for taking the time and the rigor to explore this issue. It's not a simple one. It's not an easy one to spend time looking at. We're talking about massive populations, and we definitely want to echo the impact that prediabetes is having in the population. It was quoted, but I think it's worth repeating multiple times that 37% of the U.S. population has prediabetes. 47% of those adults in California are estimated to have prediabetes, and I think it's definitely something that we as a society need to work on, and we're very proud to be part of that. I want to simply state up front that we absolutely concur with the results of the review, appreciate it. We think that it's appropriate to give B+ ratings to both the digital and the in-person group performance. And I want to add a little color from our perspective on what is actually happening in these programs. These are at their heart self-management programs. We're talking about engaging and empowering people to understand how their life is going to impact their health and how we can make a difference in that trajectory for them. So at the heart, while we want to think of delivery in a similar model to medication, we're not giving something to someone. We're not doing something to them. We're doing something with them or for them. And at the heart of that is this idea of empowering them. And so what's fascinating for us, for the thousands of people we've had the opportunity to work with, is when you ask them why are they doing this, certainly fear of diabetes, fear of health complications is part of that. But as we've all heard, the impact that has on their life, from things as simple as how they appear, to the fear that it's causing, to the dynamics that generates in their family, those are the real motivators. And so what's, I think, the brilliance and the genius of the DPP is to layer a curriculum that we know works in terms of clinical impact, but to do it in a way that reflects back to the person so that they're at the center. So the heart of what we do and the way we think about this is how do you help someone set a personal action plan? How do you help them make a goal that matters to them? and then wrap that with the education, the social support, the peer support, the coaching, and then the ability to track that progress so they see those ups and downs. So we don't think this is something we do to them, but it's something that happens with them. And when we're successful, we empower them to do that. So that is our sort of approach to it. We've seen that play out across multiple people, and the heterogeneity, not just in who the people are, but why they're doing, is phenomenal. So, when mothers come on, they'll often talk about their children, not surprisingly, but there are other things that matter, whether it's gaining time back, whether it's being able to go out into their community in a different way. We've had seniors who talk about doing this together with their spouses so that they can go on walks. And so, starting from that individual, we know we can do that. What I think is different, and there was an interesting discussion about how does this compare to sort of commercial weight loss programs, is it's not just, and then go do these things. It's not about, we're going to give you a pill or we're going to give you a bar to eat or something, but it's about helping them resonate with what matters to them. So I wanted to give some color on what's actually happening under the hood of this intervention, and then talk about how we do it at Canary Health briefly. We don't think, again, that it's something that happens outside of healthcare. All of our programs roll out in connection to a health plan or to a provider. It's connected when it makes sense to their clinicians. They can see that data back. It's connected to the other programs that those plans are providing. And so when we talk about maintenance and integration, part of that is what's the ecosystem of care that they're getting, and how does this fit into that, not to replace it. I wanted to just add a couple comments that I think were referenced in the report, but that I think could be extended slightly, and they've been echoed here. We believe deeply in choice. I think Dr. Albright spoke very nicely about how too much choice is overwhelming, but enough choice is empowering. And again, if we talk about empowerment and helping someone change, we have to start with choice. I didn't get the chance to mention I'm a health economist by training. Spent a number of years actually teaching, I guess, down the road. It's a little bit east of here at USC. And so I have a real respect for what it takes to do economic analysis, a real respect for the rigor of those studies, especially at a population level when you're talking about matching cohorts or doing randomized controlled trials. And I think it's absolutely necessary that you have the rigorous studies you've looked at. But I think we're potentially missing what I know the group here calls gray literature, but we talk about quality improvement programs or programs that are happening out in the real world. All of our clients, not surprisingly, are looking at results, so they're all tracking whether we're achieving weight loss outcomes or we're doing that. And so just to conclude, I'd like to say that our outcomes are as good, if not better, in the real world as they are in the clinical trials, and that the way these programs actually roll out to tens of thousands of people have been as effective as what you've seen in the literature. Thank you. Appreciate the opportunity to share. And are we going to take questions now? Or?
Thank you. Yeah, questions now. Yes, questions? Hearing none.
I'll throw in one. I was curious about your thoughts on maintenance programs and what your approach is.
Yeah, so our general approach has been to continue to provide support to individuals as long as they want. We treat maintenance in sort of two ways. As I said, our programs fit into the ecosystem of whether it's the provider or the plan. So often they have other services already in place. So if that makes sense, we'll refer into those or we'll support that. For us, mainly what I think we think is the modulating element, and it's really what drives at the cost, is the coaching. So what we do is we provide the access to the tools, to the tracking, to the social support on an ongoing basis, but we will take the amount of coaching down. And we find that to be effective. People continue to engage with it, and we get this continued support, continued outcomes at a lower cost after year one.
I'm curious specifically how frequent, say, in year 1 to 2 or year 2 to 3, is the maintenance touches with your program if people are staying with your program?
Yeah, so we provide both proactive outreach from our coaches. That moves to monthly after the core session, so that would continue. But the participants still continue to have unlimited access to the coach. So they tend to move from sort of a weekly deep interaction to more likely a monthly interaction.
Thank you very much.
Thank you.
Our next speaker, Mamta Gatar. I hope I'm pronouncing that correctly.
It's Mamta Gatar. Thank you.
Thank you.
I'm with YMCA of the USA, no conflicts, so I just have a statement that I wanted to read.
Could you pull the microphone down? I'm having a little trouble hearing.
Is that okay?
Much better.
Awesome. Okay. So thank you for the opportunity to share learnings from YMCA of the USA on the implementation of the YMCA's diabetes prevention program. for allowing us to provide additional comment, and for undertaking this effort, as it really helps to validate our work and the work of many others in this room. As a little bit of background, the Y is a federated nonprofit organization with over 800 YMCA corporate associations throughout the country, each of those having their own governance boards. These associations include single unit and multi-branch YMCAs. The YMCA's diabetes prevention program is being delivered by approximately 250 YMCA associations in over 1,500 locations, which include both Y branches and locations throughout the community. For CDC's diabetes prevention recognition program purposes, Ys achieve recognition at the association level, but this doesn't reflect the breadth of classroom locations and program availability throughout the country. To date, our national average weight loss at the end of the program is 5.5%, and internal financial analysis has demonstrated that over time, average cost per participant continues to decline as local Ys enroll more individuals in the program and become more efficient in their delivery. The CTAF report does a great job discussing the field, so I wanted to share a few comments on that. As highlighted, this CMS actuarial analysis certified cost savings of $2,650 per enrollee in the WISE CMMI demonstration project over 15 months, which helped contribute to the proposal to expand coverage of the DPP to all Medicare recipients. Very exciting, but there's a lot of work that remains to ensure DPP models are implementation ready and that any provider eligible for Medicare reimbursement is performing to the highest levels of fidelity to prevent issues of fraud and abuse. And while Medicare advancements are significant, there's still much to be done around Medicaid and supporting program access among low-income individuals and underserved populations. DPPs will need to identify and train staff who can deliver culturally relevant and competent messaging, and program providers will need to be prepared to address the access issues such as transportation, childcare, et cetera, that may make it difficult for individuals to enroll and remain in the program. Within our data set, 20% of program participants are below federal poverty guidelines. We believe it is our mission to support all individuals who qualify for the program regardless of their ability to pay. This is relevant because our data show that participants below the federal poverty line on average achieve lower weight loss, nearly a percentage point lower than participants who are above the federal poverty line. To whatever degree this trend is consistent across program providers, and several of us are seeing this trend, we should be mindful of the potential for organizations to be disincentivized to serve low-income individuals when public and private payers are reimbursing based on achievement of the DPRP standards. Socioeconomic factors can make behavior change much more challenging and should be taken into account. More widespread coverage of the program by Medicaid may go a long way in addressing some of these challenges and generating additional impact in our communities. So thanks again for the time, and we hope, based on the evidence amassed and commentary shared, that the outcome of today is as favorable as possible in terms of care value for these programs.
Questions? Could you tell us how many people you have enrolled in your program?
Just over 45,000.
How many?
Just over 45,000.
And how long have you been at it?
So YMCA of the USA connected to the diabetes prevention program beginning in 2010, so about 6 years.
So sort of same question that I asked Mr. Duffy. Two questions. What kind of priority do you place on taking this rich fund of information that you must have and publishing it? And what do you consider the most relevant clinical endpoint to show the effectiveness of your program?
So for our program, and we don't have any, we don't measure A1C formally as part of the program, so we do use weight loss as the primary proxy for diabetes risk reduction, diabetes prevention. The YMCA we're a community-based organization. Our position is, we try to partner very intentionally with academic institutions to help support research endeavors. We don't have any post-program data, so for our participants, they're in the program for a year. There are no formal ongoing maintenance structured sessions after that point. However, we know that many Ys continue to support their participants, whether they offer up space for folks to meet together or host alumni groups. So it is a priority for us. It's just not something we own, and it's working closely with our research partners to do so.
Thank you. Yes.
I appreciate your comments about the difficulty, particularly for people who are poor, to be able to continue participation. And we all, in so many venues, talk about the challenges around childcare and transportation. So it's not that I expect you to have done it, but I want to know whether, given that we know that's a problem in so much of what will help people to improve health, is the Y actually addressing that directly in any of in its programs?
Yeah, so most of the classes that are offered in Y branches also offer childcare. It is one of the typical services that the YMCAs provide. It's more challenging to do that in community locations because we're not licensed to provide childcare outside of the YMCA. We do know a lot of local YMCAs that offer transportation dollars, maybe bus passes, or even partnering with local departments of transportation to pick up participants for free. It's nothing that's systematized, but it's based on our learnings. Without those additional supports, participants, even if they are really motivated to change, can't continue to attend the programs.
So do you include those in your program costs when you talk about cost effectiveness?
Yep.
Thank you very much. Our next speaker is Michelle Mendoza. Ms. Mendoza.
Good morning. My name is Michelle Mendoza, and I'm the Vice President of Field Operations for Weight Watchers. It's a bit ironic that Weight Watchers is standing between lunch. Thank you for inviting Weight Watchers to provide a brief statement today, and I'm delighted to be here to provide our statement. Weight Watchers appreciates the Institute for Clinical Effectiveness Research and the California Technology Assessments Forum to review and synthesize the available evidence on diabetes prevention, efficacy, and value. The report is an invaluable contribution and resource to all healthcare stakeholders. It provides important, unbiased information for third parties on the most effective diabetes prevention programs. Its findings provide clear direction for payers, providers, and consumers on diabetes prevention programs that deliver both efficacy and value. The Weight Watchers science team would like to extend appreciation for ICER's scholarly and professional work. The Weight Watchers science team read the final report and believe it provides an accurate and concise review of the scientific evidence on effectiveness of diabetes prevention programs. Weight Watchers has a long-standing and enduring commitment to science, and its entire program is scientifically tested. We are pleased that the ICER included our randomized clinical trial that demonstrated the efficacy of the Weight Watchers curriculum and program in the prevention of type 2 diabetes. Late last year, with a one-year data analysis of our clinical trial completed, Weight Watchers became a CDC-recognized provider of DPP. We believe that the addition of Weight Watchers to the National Diabetes Prevention Program begins to address some of the scalability issues identified by ICER in its report. On a weekly basis, Weight Watchers operates over 16,000 Weight Watchers meetings in over 3,000 locations across the U.S., and a consumer with prediabetes may begin the Weight Watchers program when they are ready to take action, without waiting for a cohort to form or the beginning of a class series. In California alone, Weight Watchers operates approximately 1,700 weekly meetings each week. The evidence is clear that obesity is an important and modifiable risk factor for diabetes. Equally clear is the clear impact that modest weight loss has in preventing type 2 diabetes. Translating the scientific evidence on diabetes prevention into the conduct of routine screening, referral to DPP, and coverage for DPP will have powerful effects for the 86 million people with prediabetes. Thank you for your time, attention, and help in transforming healthcare delivery from a system almost exclusively focused on disease treatment to one that incorporates health, wellness, and disease prevention.
Thank you. Questions, comments? Yes, Dr. Rensler.
Yeah, I was pleased to hear about the number of sites of your meetings. What's Central Valley? What do you have going there?
I'm probably ill-equipped to speak to it, but we certainly do have a presence within the Central Valley. We have about 15 territories in California, and the Central Valley certainly incorporates one, each territory operating with about 150 meetings, 130 meetings. We have a mix of about 1,500 stores, sites, community locations, churches where we operate, and about 250 additional meetings where we can come to your workplace and provide the services there.
Christina.
Yeah, kind of the same question that we were talking about earlier on in the program. What do you see as the difference between this program and what the ordinary Weight Watchers weight loss focused program is? I mean, where is the difference in the diabetes prevention?
I'll try to speak broadly to it as I do represent field operations and unfortunately not the scientific community that many people do represent here. In December of this year, we launched a new program called Beyond the Scale, which takes into account 3 pillars: food, fitness, and fulfillment. So it gets to a little bit of the depression that you spoke to earlier. And in that, all our key pillars of the program. So, our current program does take those 3 things into account.
Yes, Dr. Gregory.
So you've evolved a little bit over time from the weekly meetings where you had to be there to also now having an online presence.
That's right.
Do you have a sense of how many people are choosing one or the other with this particular program, or?
Generally, about 60% of our consumers come in via the online channel and 40% come in via the meetings channel. But the meetings, we have also incorporated a personal coaching line, which is a bit of one-on-one support as well as the online offering. Meetings incorporates both the online community that we have, cell phone app-based tracking, as well as an online community that's quite robust, as well as the in-person meetings, which are held weekly, which people can engage in.
Thank you very much.
Thank you very much.
Our last speaker is Gladys Block. Dr. Block.
I want to thank ICER for a really fantastic job, and thank you, the CTAF, for an opportunity to tell you a little bit more about our program and address a few things. I had something written, but there's so many ideas that have come up that I'll sort of probably not follow the script exactly. I'm scientific director of Turnaround Health, which is the fully automated program. We're a newcomer on the scene. Partly that gives us the advantage of having been able to incorporate some of the later findings than those from the year 2000. I'm a nutritional epidemiologist by training, and that led to an expertise in not only assessing diet and physical activity, but how to change it. So that's sort of how we got into this. And so our program, which is called Alive PD for Prevent Diabetes, it involves small step goal setting, weekly goal setting, which is highly tailored to the individual, what they've told us they need, even to the degree of, is it 2% milk or 1% milk, highly tailored to what they're eating now and what their physical activity is now. Adherence was raised, engagement. We actually, for a fully automated program, that's completely an understandable concern. I think our engagement in the randomized trial was really excellent. We had 71% of people were still engaging at 6 months, and 50% were still engaging at 1 year. ICER rated our program as lowest in cost and highest in scalability, and said that we're, what was the phrase they used? Appear to be effective. And not only that, our glycemic values were actually better than most other programs have seen. And in fact, although it wasn't mentioned here, our glucose, change in fasting glucose was actually phenomenal, 7 milligrams per deciliter. But ICER expressed uncertainty about the estimate of the economic impact. And part of that reason was that 2 different estimates that could be made from our data provided a wide range of what the economic impact would be, all of it in the cost saving, but quite a range in the economic impact. So I wanted to explain to you a little bit about how that came about. What I really want you to know is that we have 1-year data from actual incidence of diabetes in our sample. We observed who developed diabetes in the control group and who developed diabetes in the intervention group. Using fasting glucose, more than twice as many people developed diabetes in the control group as in the intervention group. It was resulting in substantial economic impact. It was 21 people, or 12%, developed diabetes by fasting glucose in the control group, and only 10 people, or 6%, in the intervention group, when you define it by fasting glucose. And that's clearly good evidence of diabetes, of preventing or at least delaying diabetes. When you calculate it by hemoglobin A1C, the effect looks smaller, but the reason is that there were only 2 people on our entire 300-plus sample who developed diabetes by the hemoglobin A1C criterion, because we had very low hemoglobin A1C in our sample. More than half of them were in the normal range. They weren't even pre-diabetic by A1C, whereas by fasting glucose, everyone was pre-diabetic by A1C. I mean, by fasting glucose, everyone was pre-diabetic. So I just hope that the committee will take into account that the uncertainty ICER felt was because there were only 2 people to prevent when you look at it by A1C, whereas we actually have 50% reduction when you look at it by fasting glucose. So we significantly prevented or delayed diabetes using this scalable and affordable program. Thank you.
That the data that you just described, the 1-year experience, was that published?
That has not yet been published.
I would just explain that the way we work is we base our deliberations on evidence which has been published in peer-reviewed journals, and that's been part of the frustration that there's a lot of potential data out there that isn't published, and I think you weren't really overlooked, but it was hard for us to make a judgment without it going through a peer review process if it were published.
Sure. I'll also mention that those data that I just reported, I acknowledge your point that it's unpublished, but that was intention to treat data, so everybody who enrolled, we followed them, so we had good quality study.
Yes.
Recognizing, as Dr. Albright said, that there are going to be different kinds of programs for different people. We don't really know for whom each one will be appropriate, and to offer a small menu is going to be necessary. One of the questions that comes up is the kinds of patients who choose a virtual-only program and whether they are at comparable risk, less risk, than those who might better engage with programs that have some either synchronous or desynchronous human coaching. So one of the challenges is around how effective this kind of program is beyond one where patients were enrolled on their own by sort of looking online and finding this program.
Yeah. I personally think it's really important for people to have a blood test, or at the very least to have a doctor tell them, you have a condition that is likely to progress. And so I'm not seeking for people who just happen to find us on the web. I think you're right that their commitment is likely to be less than if somebody in the medical profession told them they really need to do something about this condition. So what I would like to be able to set up is a situation where people in the medical community or people doing health fairs where people actually are diagnosed with prediabetes would be recommended.
Have you any information about those who tend to succeed in your program to say, for example, as a clinician, we would, if we're going to offer a menu, to be able to say, the kind of person who does well in a virtual-only program, which is very cost-effective, so that we have a better sense of how to help guide people to different options?
Right. It's really too early for us to tell, I would have to say. people participated very well and did very well in our program. One thing that's notable is that in our randomized trial, almost 70% were male, which is just the opposite of what most programs usually see. So honestly, I can't tell you that that's why they did well or that males would normally do better in our program, but it's possible that, you know, men maybe less need or want personal contact.
Dr. Eisler.
I just want to strongly support what our chairman said, and that is I personally am really happy to see a lifestyle-changing preventive medicine approach being reviewed by this body and being promulgated by a government entity. It's refreshing. The only reason I can't totally embrace this as being of proven superior clinical effectiveness and being high care value is the lack of longer-term published peer-reviewed data. So it has nothing to do with where I'm personally coming from. It's just we've set our standards, we've used them for years, and in order to avoid being whipsawed by current fads, you've got to go by peer-reviewed data. So cheers, keep it up. It's wonderful.
Thank you.
Dr. Gregory.
Yeah, I'm just wondering if you're completely online, is there a possibility or any thought, especially given that there is some benefit to personal contact, at least for the people who fall off? Or is there some kind of tracking to say, oh, this person isn't checking in anymore, maybe we should have a human contact?
That would be a great idea, I think. I mean, clearly some people will fall off in this kind of program, and ideally we would be able to recommend then some personal contact. We have the capability of setting that up. We haven't done so in our trial, but that would be a possibility that we could select just people who look like they're in danger of falling off.
Thank you very much.
Thank you.
Matt, do you want to guide us?
So now we will break for lunch, and we're running a little bit behind on the agenda, so we were planning to reconvene at 12:45, but we'll reconvene at 1 o'clock to give everybody the full half hour for lunch. I'll put that up on the slide as well.